Welcome, everyone, to the third session of our multidisciplinary new Grand Rounds training concept in child protection. We're calling this the ISPCAN Huddle, and we're so excited to have you with us today. I'm the CEO of ISPCAN, Pragati Tamala, and I'm so excited to debut this concept for the first year. While we're doing it online, we still encourage you all to be actively discussing and participating in our breakout sessions. We want this to be an active discussion where we dive into a case and we really start to break it down and understand where we could have done better. As you all know, ISPCAN is an organization where our members improve systems of care in every nation. And we really want to raise the bar on how we are currently managing cases of child sexual abuse. In this first year, we're going to dive into this case, and we really are looking forward to hearing how it's working for you in your regions. The huddle, we came up with this term because we really wanted it to embrace this concept of when people huddle up and really gather together in a closed circle and think about how can we approach things in a team mentality. So this term we affectionately liked because we imagined it to be what we wanted for all of you as participants to feel as you came together in this learning concept. I have so many people to thank for helping us to brainstorm this concept, to help us put together the curriculum this year. Many people were involved to make this such an exceptional first year's case. And I especially want to thank our partners at Haruv Institute and the Kemp Center, as well as our partner, the Zoma Foundation, who is funding our evaluation of this effort. So thank you to all of you who have really helped us bring this concept together. The basics of this concept is essentially a grand rounds concept. We wanted to take each year a different type of case of child abuse and neglect so that we could really look at it from an objective point of view in retrospect to think about what it is that's working and what it is that we may need to look at differently, holistically, and change so that we don't keep making the same mistakes. In year one, we're taking a case of child sexual abuse. And this is a multi-generational case of child sexual abuse. And we want to look at the context of culture, family, and how these systems of care, the multidisciplinary aspects of systems, come together to really interact and protect and heal the child. So we're going to dive deeply into this in year one. In year two, in 2026, we plan to bring this huddle and this case of child sexual abuse into the regions. This would allow us to adapt the curriculum to the cultural context, as well as particularly in certain regions, make it language specific. This huddle will be delivered in person through our country partners and the regional hubs that ISPCAN plans to establish in the various regions around the world. In the third year, we're looking at a case of online abuse and bullying, and we will break down this case the similar way that we have in year one. The key objectives of this huddle is that we are planning to understand what are the current global challenges in cases of child sexual abuse. We want to really gain insights to what you are seeing in your regions and what are the challenges that you're facing when we are intervening and dealing with cases of child sexual abuse. We hope to learn the best practices, explore these cutting-edge strategies, and bring forward a diverse global perspective. We also want to enhance multidisciplinary collaboration, which we know is the most effective way for us to work smarter and have the best outcomes for children. We want to make sure that our members are able to update their skills and knowledge, have access to the latest tools and resources to address child sexual abuse effectively. And most importantly, we really want to cultivate this professional network so that you all feel this community of learning and support as you do this very difficult work. The approach we're taking in improving child protection and practice is looking at these multiple sectors that must come together when we're looking at cases of child protection, excuse me. So we're going to look at the medical assessment and treatment, the mental health and support systems, the legal process, justice and reform, the social work case management, community resources and referrals, and put it all together in the public health prevention and policy context, looking at additionally funding and resources that are available in your regions, all within this multidisciplinary approach and context so that we can coordinate care and really look at how effective outcomes are for children. Last week, we talked about public health interventions, and I'm going to summarize what we found in this discussion. But the key here is that we want to make sure that we are using prevention-focused actions at a population level. For this to occur, we know that universal service delivery platforms are the most important to provide this baseline for all children and families to have the most successful chance at good outcomes. And that, married with community-based actions and population-wide strategies, are going to ensure that from the top and from the bottom, families and children are well supported. This 360-degree case analysis is really critical because we want participants, to think differently and really think about new ideas for their region. We want to identify the gaps and opportunities for improvement in practice and policy, and think about how can we frame these key insights and take-home messages so that everyone can gain from this knowledge that we come together and the challenges that we find that need to be addressed. Currently, we know that these challenges in child protection are just going on and on. Our staff and our workforce is overburdened. We have inconsistent standards and practices that affect the quality of care that most children receive. There are grave racial and socioeconomic disparities, cultural and social norms that we need to take into consideration, as well as in this case, we see trauma in adults that is passed on from one generation to the next. In order to address these challenges in the huddle and beyond, we really want us to take a certain strategy and approach. We want to look at multi-system preventative approaches, how we can strengthen the workforce, enhance our social protection, and standardize practices. This case in year one that we're looking at is a case of child sexual abuse that we see through the eyes of the child. Sasha Joseph Newlinger uniquely shares his story, puts together his home movies. Through his narrative and discussions with family members, we really see from his eyes and his perspective what happened. We hope that you had the chance to watch this film in session one and even in between to understand and maybe take notes to look at what were those missed opportunities. We wanted people, as they watched the film, to watch for different key aspects of the case that we would identify and analyze over these next 4 sessions. Last week, we started with identification. We focused on what were those missed red flags that professionals, families, and other missed, what hindered and promoted the disclosure, and what prevention steps could have been taken. This week, we're going to focus on the assessment. What were the main challenges that Sasha faced? How could trauma-informed approaches been improved in the process? In the next 2 weeks coming up, we will break down the multidisciplinary response and the follow-up and resilience. So if you are interested in those 2 upcoming sessions, please make sure you go to the website and register for those. If you missed the first 2 weeks, we thought we would do a quick summary of what you missed so that we can also use that knowledge and apply it as we move into this next session. So in session one, when we were looking at what the coordinated child-centered approach was, there were certain challenges that we identified in the child protection services. This under-resourced system, inconsistent standards across regions and countries, the racial and socioeconomic disparities, as well as this intergenerational trauma that gets passed on when it's not effectively addressed. Last week, as our experts looked at the identification and disclosure barriers, there were certain themes and topics that came up. It was noted in our breakout sessions that CSA often goes underreported or misinterpreted due to these misread flags and signs. There is a very deep-rooted stigma and shame, often related to cultural norms that hinder the disclosure and reporting of abuse cases, especially amongst boys. The social perceptions about children with disabilities often shape how sexuality is perceived, which often also affects how cases of sexual abuse are identified and handled. And what was really interesting is that professionals themselves admitted to sometimes lacking the confidence in how to respond appropriately to these disclosures of abuse. Often there was insufficient training as well as resources in their regions. So they admitted to being a bit hesitant to report abuse at times. So when we look at these issues, we think about what can we do better? We need to engage in more efforts to increase awareness of child sexual abuse among professionals, parents, and children, promote social messaging aimed at reducing the shame and stigma regarding CSA, work more collectively at the individual, organizational, and community levels to change norms that discourage disclosure, and most of all, create an environment in which children and caregivers feel safe to disclose abuse. We also explored this question around mandatory reporting. Most people agreed that it's an important policy, but it was insufficient alone and often comes too late in the process. Once abuse is reported, again, we noted that there were limited resources to ensure an appropriate response. Professionals often report to the wrong entity or avoid reporting due to fear of legal consequences. So a lot of pediatricians in the room admitted to avoiding asking questions directly to children about abuse. And we really want you to remember that this is a safe space, an open space, and the breakout rooms will not be recorded. This is our moment to really be honest about some of the things that hinder us when we do this work. When reports were also not followed by any feedback, professionals often perceived that their efforts were ineffective. Therefore, then in the next case, diminishing their willingness to report in the future. So again, here we ask the question, what could we do better? And it bubbled up that proper training for professionals and increasing awareness about the legal protection for those reporting would be a great improvement. And in addition, we would promote an option for anonymous reporting so that mandatory reporting could still occur, but it wouldn't necessarily be tied to individuals who had some burden on them then for follow-up. And it also was noted that we could do better with systems being more prepared to respond to these growing numbers of cases and caseload. And then our experts talked about the public health model. It really was emphasized that all professionals working with children need to understand that they play a role in identifying child sexual abuse and intervening. They have a duty to step in and advocate for them, and that effective child protection does require this coordinated multidisciplinary approach. And this proactive framework with prevention-focused actions, universal service delivery platforms, and community-based actions, promoting population-wide strategies is the most effective way that we can address mental health and all of those early important developmental strategies, as well as positive parenting, and the many things that would provide primary prevention of child abuse. The model prioritizes universal screening as a strategy for early identification, recognizing that all children are at risk. It shifts the focus from that crisis response to early intervention and prevention. It really aligns with this ecological theory of child development and recognizing that the risk factors and protective factors in all systems of a child's life and the ability to target both at all levels would be required for effective intervention. And to do this, there are some obvious problems and limitations. Implementation is limited by many funding gaps and short-term policy cycles. Systems have to be prepared to respond to the growing number of cases again. And in terms of solutions, we realized and recognized that governments need to make long-term investments to see the potential return on investment for prevention, as well as the substantial infrastructure that would be needed for this type of systemic change, requiring things like mental health to be part of universal services and care from at a young age, starting at a young age and beyond. A possible solution would be to begin at a local level and gradually expand. Some other effective and central strategies that were identified would be that training for all professionals working with children, as well as parents and children, would help them identify and respond to CSA disclosures. We could make more use of digital tools and online platforms to enhance the effectiveness of these programs. We could promote conversations about disclosure while making children and adults feel safer and more comfortable sharing. We would be able to address the barriers to disclosure and reporting of CSA, especially around the issue of stigma and shame with boys. We needed to do more support of frontline workers, helping them to respond effectively to disclosures of abuse, and promote these community-based child protection systems led by local leaders so that multidisciplinary teams and collaboration could occur between family and local governments. Every community is going to look different with different strengths, and they should develop their own tailored response model suited to their specific needs and available resources. And we will go into this more next week when we talk about the multidisciplinary response. And finally, the point was made that we needed more experts by experience. The adults and survivors, children who have undergone CSA, would be instrumental in helping us to shape effective research and policy changes in the field. So now I would like to go ahead and introduce our next session leaders, Afnan Atrash Najar from the University of Oxford, and Denise Abdu from the Pediatric University at the Colorado School of Medicine and the Children's Hospital Colorado Child Protection Team. Afnan and Denise are going to be leading us through this next session, and I'm going to go ahead and turn it over to them.
Thank you, Pragati, for this insightful introduction, and thank you all for joining us today. Just one moment, trying to find my slides. Just taking this aside. Can you please confirm that you see the first slide and that I moved the second one? Perfect.
Yeah, it's good. Thank you.
Thank you so much. So I want to start by sharing a story that sets the stage for our discussion today. And it's about a brave young girl who disclosed ongoing abuse by her brother. And after the disclosure, we have conducted a forensic investigation, and it became clear that medical assessment was crucial. However, this girl lived in a resource-limited area where there was no hospital equipped to handle cases of child sexual abuse. And as a result, we had to travel 40 minutes to the nearest hospital with trained professionals to carry out the medical assessment. And I could tell you that drive wasn't just long. It was filled with confusion and lack of clarity. The girl didn't know what to expect, and the trauma she had already experienced made everything feel even heavier. And before we left, we did our best to prepare her to the assessment. We explained on the medical assessment, answered her questions, and also told her that she could signal when she felt ready to go, trying to give her some sense of control in a moment where so much had been taken away from her. And once we were in the car, silence filled the space. I wanted to support her, but I didn't know what to say. The silence was and felt heavy. It was clear that this silence was not just about the physical distance we were traveling, but it was about the emotional distance, and I might say challenging situation she was processing in that moment. So I tried to help her and thought about this a lot and asked her, what would make this drive easier for you? And she stayed quiet at first. She was silent. But then she told me that she had a notebook and a pencil in her bag and wanted to draw. After a while, she showed me her drawing and began to explain it. And that drawing said more than words ever could. It was her way of telling her story and sharing her feelings. And that moment taught me something I'll never forget. Sometimes it's not just about saying the right things, it's about being present, listening to what is not said, and creating space for children to lead in their own way. And this story reminds us of Sasha's story. Sasha, like this girl, communicated through drawing, and his drawing was not just a picture. It revealed what he was feeling inside. Children often aren't able to express their feelings through words, so it is important to give them space to express themselves in their own ways. As we reflect on this powerful story in Sasha's drawing, we can begin to consider what a high quality assessment should look like, not just in procedures and checklists, but in how it responds to the child's emotional and psychological needs. And to guide us through this conversation, let's take a moment to outline our objectives for today. We want today to discuss the importance of high quality, holistic assessment, to explore the ecological model as a framework for assessment, to emphasize the importance of child's voice and needs through this. And finally, we want to address the practical challenge and systematic gaps in child sexual abuse assessment and think together what might work to address these challenges. With these goals in mind, those are the guiding questions for the breakout rooms that will help us to think together about how assessment practices can be improved. So the guiding questions are: what practices have helped you or your team or might help you to conduct high quality child-centered assessment in child sexual abuse cases? What point in the assessment should professionals approach the medical assessment and why? And how we can ensure that the assessment is both trauma-informed and sensitive to the child's context. And now let's explore together why doing it right truly matters. And this question invites us to examine our own approach, to understand the profound impact and the consequences when assessments are not done right. And such a story illustrates this in a very powerful way. Despite years of visible distress, his sudden drop in academic performance, his avoidance of school, later his emotional struggles and behavioral issues, the professionals around him failed to ask the right questions or to connect the dots. And when his mother raised her concern on the sexual abuse with a doctor, she was told, "You don't want to open that door." And this chilling may say advice delayed the intervention and caused ongoing suffering. So I want to say that a proper, timely, and trauma-informed assessment could have uncovered the abuse earlier, preventing further harm and beginning the healing process much sooner. And what happened in Sasha's story emphasizes why it's so important to carry out careful and high quality and coordinated assessment. Without proper assessment and without proper coordination between professionals coming from the different sectors, children may be asked to repeat their story again and again, often in confusing or stressful settings. And this can lead them to feel overwhelmed, stressed, unsupported, and even, unfortunately, to recant what they shared, to take back what they shared, not because the abuse didn't happen, because the process itself is distressing. So poor assessment also can lead to wrong decisions. When we miss the warning signs, the child remains at risk, and in the most severe cases, this can result in serious injury or even death. On the other hand, as we see, a well-coordinated, trauma-informed assessment can make a real difference in children's lives. When a trained professional conducts a single forensic interview, it reduces the risk of re-traumatization and recantation and helps to protect the integrity of the child's statement and testimony. And when professionals collaborate and take a holistic view of the child's situation, it ensures better protection and care. Now let's take a look at how to do it right. To do it right, we focus on 6 important elements, and these elements support a thorough and an effective assessment. We're talking about collecting data and information, assessing the risk, multidisciplinary coordination, emotional safety protection, child interview, and cultural sensitivity. And before diving into these different elements, we want to make it clear that high quality assessment is not just a checklist. It's a comprehensive process that helps us to understand the full picture of the child's situation. This means looking at their emotional, physical, psychological, and legal needs as interconnected pieces of the puzzle, not as separated steps. And each part of the assessment informs the other parts of the assessment and lead us to have effective decision making. We need also to acknowledge that in practice, the timing and the order of the assessments may be different depending on the case and also dependent on what available resources we have. So these may say points are so important, but one element must remain consistent across all the contexts, and I do believe that across all the regions, which is collaboration. Whether professionals are not in the same location or whether they work in different systems, coordination is essential. Children's needs are complex, and no single discipline can meet them alone. So if I want to put this in simple words, I would say that the assessment is not just about collecting information. It's about ensuring that no aspect of the child's care and protection is dismissed or overlooked. And all of us know that child sexual abuse never happens in isolation. It's never happened in a vacuum. And the ecological model helps us to assess not just the child, but the world around them. And this is the reason for choosing the ecological model as the foundation for the assessment process. We need to understand the full context, the child, their family, their community, and the prodigal systems they interact with. And the ecological model helps us doing so. It guides us to consider all the layers that influence the child life, so we can respond in a way that truly supports their safety and well-being. And before moving to the next slide, I want to share you a valuable lesson that I learned from one of my teachers during an intensive child protection course. She told us, every intervention you make to protect a child comes with a cost. So collect all the data needed, think carefully, assess carefully, and act in a way that protects the child while causing the least harm. And this is exactly why assessment matters and why it must be grounded in a broad ecological understanding. So when you want to assess the child, we need to look at the whole picture. And this means understanding not just what happened, but also how the child is functioning in different areas of their lives. We look at their physical health, any injuries, ongoing health issues, medication, medical history that could give us some clues about their experience. And we saw that in such a story, his mother noticed a small injury on his genitals. And when she asked him about that, his response made her more concerned. The second area is the behavioral and emotional signs. For instance, we could look for change in mood, signs of trauma, self-harm, unhealthy coping responses, for instance, like substance abuse among older children, And regarding the changes in mood and emotional signs, we saw that Sasha showed emotional disengagement, confusion, and deep self-blame that was captured in his drawing when he wrote, "I'm a loser." The third domain that I want to emphasize is the school and social functioning. We need to consider the child's performance at the school, attendance to the school, relations with his peers and friends, and any change in their behavior at the school or at the home. And we do remember that Sasha's mother described him as a joyful in kindergarten, but once he moved to the school, he rapidly declined, refusing to go and wasn't keeping up. The fourth thing I want to emphasize is the narrative and the voice. Most important to listen to the child's story, how they describe what happened, how safe they feel, and how they understand their situation. We need also to understand whether children were involved with child protection system, mental health support, or other agencies. And finally, we need to conduct this assessment in a way that ensures emotional safety, using trauma-informed practices like neutral safe spaces for interviews and careful listening. Next, we need to zoom into the family. We want to understand who lives in the home, how the family functions, the family dynamics, and whether there are signs of stress, secrecy, or danger. We look for reports from informal and formal systems. And we also need to consider the family history. If there is domestic violence, any specific dynamics that we should consider, and as Pragati noticed, the intergenerational trauma. And we saw that in Sasha's case, his father had been abused by his own brothers. And this unresolved trauma may have made it harder for him to recognize the signs of his son's abuse. And here I want to briefly cite Judith Herman, an American psychiatrist, one of the well-known researchers in trauma studies. She explained that survivors often develop avoidance as a way to cope, and without proper intervention, this avoidant pattern might persist, making it difficult for them to face painful realities. And saying that, if we go back to Sasha's father when he reflected on the old home videos, he told us, those are happy moments. In the background, stuff was going on. And now, when I see these films, I see them. And I want to say that his words remind us that trauma often goes unnoticed, not because it is not there, but because it can be too painful to see it. And also I want to emphasize the need to assess and evaluate the siblings' situation. We know that from research and from practice, siblings are often co-victims or witnesses to the abuse. And in Sasha's case, he said, I didn't want my sister to go through this anymore. His disclosure was also motivated by the desire to protect her, and later it was confirmed that she too had been abused. This reminds us why it's crucial to assess sibling situation, even if they haven't disclosed anything. And lastly, I want to say that we should consider whether we are talking about intrafamilial abuse or extrafamilial abuse. And in cases of intrafamilial abuse, it's important to proceed carefully, using sometimes indirect questions and avoiding early confrontation and working with trusted professionals because we don't want any confidential data to be exposed to a third party. And regarding the extrafamilial abuse, the focus shifts to assessing how the family members responded to the disclosure and their capacity to protect the child. Then we look at the community, religious groups, local institutions, formal systems, informal systems, and sometimes these settings support children, but unfortunately, sometimes they silence them, they fail them. We have to figure out if there was a previous report ignored by the systems. But as I said before, Sasha's mother tried to seek help after noticing the injury on his genitals. But when she asked or raised her concerns with the doctor told her, "You don't want to open that door," emphasizing the consequences of disclosure on the family and overlooking the child's safety. That response silenced needed support and caused ongoing suffering. We need to review all the records that we can access to. For instance, school records, talk to teachers, and check what policies are in place. We also need to look at gaps in services, like if there is no local shelter or child advocacy center, how we can still conduct a high quality assessment within limited resources context. We recommend using the mapping method because we could understand what resources we do have and how we can address the different challenges. At the broadest level, we examine how culture, law, and norms shape the child's world. Are there policies that protect the child? Do cultural beliefs or social expectations or gender norms silence certain victims, like boys? Is there a risk of honor violence or community backlash? We analyze national policies, legal protection, and compliance with the child rights standards to make sure that our assessment fit the bigger picture. And all of the six elements are important, but I want to emphasize one of the important key messages. None will be effective without good coordination. Even if we have the best tools, the best guidelines, and best resources, poor coordination and collaboration between professionals can cause serious harm or delays in responses, and potentially this make things worse for the child. When assessing suspected cases of child sexual abuse, teamwork across the disciplines is super important. Each one of you, each one of us, whether you are a social worker, a teacher, a doctor, an investigator, or part of any other profession, brings a unique piece of the puzzle. And to respond effectively and support the child, we need clear rules, mutual respect, and strong collaboration. So, if I want to summarize this together, I want to say first, we need to define who does what so there is no confusion. Second, we have to share key information at the right time using clear and structured communication. And third, always take time to reflect. Always take time to reflect. I want to emphasize this. Talk together about what worked, what didn't, and how we can improve our response and assessment in the next time. And this shared learning is how we build better coordination and better outcomes for children. So the key tools include clear protocols to define rules, structured communication to share information, and regular reflection for ongoing learning. And now that we have discussed the importance of holistic approach to assessment, I would like to hand it over to my colleague, Dennis, who will take us deeper into one of the most critical aspects of this process, the medical assessment in cases of child sexual abuse. Dennis, it's yours.
Thank you very much. And for the introduction and the start to this information. Next slide, please. When we think about a medical evaluation, it's really important for us to think about patient-centered, trauma-informed evaluations. Our health evaluations should be holistic. They should be talking to children and their families about general health and then trying to navigate to what is your concern today. Let's talk about what concerns you might have about child sexual abuse or other types of abuse or neglect. And are there times when you've had injuries or seen any types of worrisome behavior changes, including things like sleep or eating disturbances, or injuries to the body that you didn't know how they got there or had sort of a wonky or odd history that didn't make a whole lot of sense. The other piece is really going back to that ecological model and thinking about the multiple systems that affect a child, is thinking about any type of challenging family dynamics, any history of sexual abuse specific for the mother, parental choices about who has access to their child, and how they view the child in the context of their home, as well as neglect issues or lack of supervision. I do want to point out that poverty does not equal neglect. However, there might be resourcing that either a hospital or a child welfare type of system might be able to help families with. And it's important to really think about the entirety of the family system when taking a medical history. And then always important is to think about behavioral health concerns and or substance use disorders, again, for supportive purposes, not for punitive purposes. Next slide, please. When we think clinically about adolescent and child exams, we know that there are very big differences between a prepubertal patient or a child and the older patient who might be an adolescent, not only in terms of their development, in terms of language development and or their understanding of what might have happened to them, but also in terms of what their body looks like and how their body changes over time as they go through puberty. So people who are seeing younger children or children who have not gone through puberty should understand normal child sexual development, normal behaviors that can be very typical, but sometimes worrisome to a caregiver. So things like self-stimulation for self-soothing can be worrisome for a caregiver, but might be typical in terms of sexual development for children, as well as the anatomical changes that happen over time, because what you're looking at today in a 4-year-old is going to look very different than in a 16-year-old, and understanding those differences and how that might impact the type of contact that a child has experienced is really important. And then while Afnan said the medical piece can be really important, for me, the most important thing that I do is take a detailed medical history and really thinking about a broad picture of the health of this child and narrowing down into what are the concerns today and how do those relate to any physical changes that we might have seen on the body. And again, this is for a supportive piece. When we take these detailed medical histories, it's not uncommon for children to have very interesting questions about their body that they might not feel comfortable asking, but opening up a broad picture in terms of talking to the mother, the father, the caregiver, the child can sometimes bring children to say, well, I have these questions about my body. And it opens up a very organic way to have conversations with children about bodily safety and who can touch your body in different ways when you have an injury, when you're having a healthcare appointment, and if somebody did touch your body in a way that you didn't like, who you could tell. And being open to having conversation in that moment around having people within the family that you can tell, but also people outside of the family that you could tell that something made you really uncomfortable and you didn't like it. So that if abuse is occurring intrafamilially, they have people outside of the family to tell. And the converse is also true, that if something happened outside of the family, they could tell somebody who's a trusted adult in their family. Next slide, please. So history is really important. I alluded earlier to the idea that young children have a limited speech capacity. They also have, it is also very common for there to be delayed disclosures. So when abuse might have occurred, you might not have a child tell you that that happened. Oftentimes the relationship between the child and their offender is unique, and it might not physically hurt. There also might be threats. If you were here last week, I believe we talked about threats that a child might experience. I think Dr. Krugman gave a example of a child who was on the Western Slope near Aspen, and that child having been threatened and their family having been threatened. And in instances where things like that happen, Children might not disclose until they feel like they are in a capacity to be very safe and protected, as well as those who might have been threatened in their family to also be safe and protected. And in the clear absence of in the absence of a very clear disclosure, other behavioral indicators might be important, and the context of those behavior changes can also be important. If there's a lot of chaos in a family, lots of change that's happened, so moving, parental separation or divorce, other things like loss of a family member, behaviors might change because of those things, in addition to changing because of abuse or neglect. And so it can be very, very difficult to figure out cause and effect. But making sure to think about those things in a broad sense and having an understanding of what has been going on so that you can try to correlate, if possible, these behavior indicators as well. Next slide, please. So disclosures. Adolescents who are neurotypical in their development usually make a pretty straightforward disclosure and can tell you what happened. In our medical history, we will often be very directive in talking to a neurotypical adolescent who's pubertal. So the 14, 15, 16-year-old, I can be very directive in saying, tell me what happened to your body, what touched where, and very talking about, was there body fluid contact? Was there injury? What did that look like when this happened to you? And a younger child who might have limited capacity in terms of speech and or developmentally has not reached a space where they can talk about the who, what, when, why, where, and how questions. There's a continuum in their disclosure ranging from not saying anything happened to saying lots of things happened, and then the timing of when that happened might be challenging to figure out. And again, the factors that affect a disclosure include age, the relationship to the offender, parental support or a lack of parental support, and then fear of not being believed, of being worried about threats or consequences that might happen for making that disclosure. Next slide, please. So when talking to children and taking a medical history, I think it's really important for any healthcare professional to be open-ended and ask developmentally appropriate questions. I sometimes, when I lecture, forget that I'm talking to adults, and so we'll use words like poop and pee when I'm talking about children and their body habits, because those are the words that I use on a daily basis when examining children, when talking about urination and defecation. And so using words that they use to describe their body, to describe their bodily habits is really important so that you're not trying to translate medical jargon or words that are outside their developmental capacity to them. So I will often ask, tell me about the words that you use to talk about your private parts or your genitals or the areas on your body that a bathing suit might cover. And I will use their words and then fill in the context of medically. These are the words that we would use to describe those parts of your body so that kids start to learn the anatomical terms, but also understand that that connects to the terms that they use. If children are very young, we try to get information from a caregiver without the child present so that in the event that a forensic interview might happen, we aren't impacting that forensic interview any more than we already are by doing a medical evaluation. And then really talking about body safety rules. So who can touch your body? Why is it okay today for me in the context of a medical evaluation to touch your body? Has anyone ever touched you in a way that you didn't like, made you feel uncomfortable? And really thinking about secrets. Are there secrets that people told you to keep in terms of how your body might have been touched? And who would you tell if any of those things ever happened? And when kids disclose, I again go back to very open-ended responses and saying, thank you for telling me about that. Can you tell me any more? Or what happened? Or something just very open in terms of not trying to lead or impact where a child might want to go with the story that they need to tell us. Next slide, please. Duplicative questions. It is clear that our literature demonstrates that it's dangerous to ask duplicative questions, and this is why we try to take history outside of young children and take it only from their caregivers so that they're not listening to duplicative questions or being asked those. Because ideally, a forensic interview is somebody who is specially trained to talk to children about things that happen in their lives, happen within the context of these disclosures. And so our history medically can be limited to the areas around body and injury and things that kids are worried about regarding their body, so that we can guide our medical evaluation. And should we need to collect medical forensic evidence, we can collect that those biological samples as well. Next slide, please. When we question children, this is just a nice graph that I like to refer back to, that gives you an idea of this continuum of when children have very concrete thought to when they can think more abstractly and their ages. And when you think about the who, what, where, when, how, number of times kinds of questions, you can see on this continuum that based on their age is when they can start answering some of these questions. And even when you're 13, so in theory are either starting or close to pubertal, or in some instances are already pubertal in an adolescent, you still have some abstract, thought, but you might be very concrete still in terms of number of times and timing of things. And so just being cognizant of that and understanding if the child that you're examining or the adolescent that you're examining is neurotypical, or if they've had any types of developmental delays or neurocognitive delays, that would be important for you to know when you question them. Next slide, please. So building rapport, it's not uncommon for people to say to us, well, your exams must be frightening, they must be painful. And I often say our exams are therapeutic and they allow kids a space to ask lots of questions. And most kids become comfortable with a medical provider who takes time to build rapport. We reassure kids about their exam. It shouldn't hurt. It might be weird because you haven't had an exam like this in the past, probably, but we can stop at any time and re-evaluate where we are and what needs to happen for you to be comfortable. Answering questions honestly about what might or might not happen during the exam, and being gentle when doing the exam and allowing children a position of control. So if children want to sit on their parents' lap or their caregiver's lap during that exam, we are absolutely able to accommodate things that might make them more comfortable. And depending on where you are and what your resourcing in terms of medical site and evaluation is, you might have lots of other tools to be able to utilize. So we will actually utilize iPads for distraction. So kids will be able to watch whatever kind of cartoon or TV thing that their caregiver and they agree on an iPad, or listen to music. We will sometimes utilize child life specialists to help us. And in some cases, we've actually used trained medical dogs to help distract kids during their evaluations when we have that available to us. And this is where understanding the context of what you all have available in your community is going to also be very important. Next slide, please. So the medical exam, we take a very detailed medical history. Why are you here? What's been done already? And tell me a little bit about the context of the disclosure. Was it in the context of asking questions to your child, or was it a spontaneous disclosure at the dinner table? What are the details of any specific symptoms, including have you ever had genital pain or bleeding, any lumps or bumps, discharge that you thought was odd or unusual? When was the last time that you urinated, defecated, brushed your teeth? And the hygiene questions are really to help us understand if you are in a window where you could collect forensic evidence or biological evidence, what has happened, so that the people who analyze that evidence know, because you might not see that if they've bathed 6 times between the time that the abuse occurred and the time that the evidence is being collected. Toileting habits, are there changes in terms of wetting or stooling issues that are new? Moving into behavior history around changes in behavior. And earlier I talked about things like sleep patterns, eating habits, overall mood assessment to see if there are behavior changes that could be related to abuse that might have occurred. And then talking about your social history, including history of prior maltreatment within the family, for the child, but also within the structures of other people in the family. So caregivers, parents, enter multi-generational abuse that might have happened. Exploring whether or not there's exposure to sexually explicit material. I often say that although the internet and apps are really helpful in many ways, they also allow children access to things that they probably don't cognitively understand, developmentally understand at very young ages. And I will say that they are much more savvy than somebody like myself who didn't grow up in a household with any of this because it wasn't invented back in those days. But children are now exposed on a daily basis to sexually explicit material. And what are the parental controls that people are using to make sure that we try to keep safeguards in place? And then what are your family attitudes, your cultural attitudes, your religious attitudes around sexuality and how that might impact one's a child's disclosure or non-disclosure? Next slide, please. Our exam is a full body checkup, and I describe that to children that way, that today we're going to look at your body from your head to your toes and everything in between. And I ask if there's anything that you're worried about. What worries do you have about your body? Do you want me to check any part of your body more carefully than any other part? And then we talk about the genital exam. Genital exams are part of traditional well child care. It is not an internal adult exam. It is really just looking at the outside structures and moving tissue like your labia majora out of the way so that you can see the vulva and the hymen leading into your vaginal canal for young girls and young women. And then looking at the penis and the testicle, the scrotum, and making sure to palpate testicles and the perineum for boys or male patients, and then for both males and females to look at the anus as well. We allow comfort and privacy for the child. We ask children who they would like to be in the exam room with them, but we always include that there has to be some chaperone present to make sure that they are safe and that we are safe as the examiners. Children are in control of their evaluations, and we identify normal exams and discuss what we might see. And I will say in my experience of doing exams for many years, the vast majority of exams that we see, even where there's a very clear disclosure, are normal. It is rare to have abnormal genital findings, except in cases of acute rape in older adolescents, or where there's a very clear history for a younger child of an acute rape. But what we expect is a normal exam, and that normal exam does not rule out child sexual abuse. We go back to the history, like what Sasha had told and disclosed to his mother, the drawing. Those would be things that would make me worried about the possibility of abuse. And then I would need to lean into outside agencies who do investigations to help put that puzzle of I have this piece of information together with what that means. And I do want to point out that he didn't have a normal exam because he had an injury to his penis as well. Identifying anatomy and Tanner staging, and then normal variants, and sometimes referring for concerns. So does a pediatric gynecologist need to evaluate this patient, or perhaps a dermatologist if there's a mimic or skin disorder? And Pragati, I see that there's a question regarding, are rape kits ever used to collect DNA evidence? Yes. I think I have a slide on that, perhaps the next slide. Forensics, DNA evidence. So when we think about collection of evidence in the United States, we think about, is this acute or non-acute? Are there body fluids to collect and the timing of that? Whether or not there's a history of close contact with the assailant or offender and the victim, and what is that body fluid exchange? And then also about trace evidence. So is that trace evidence on the child or at the scene where the offense occurred? And I think the next slide might go into timing. So when we think about acute versus non-acute, there are different timeframes for children versus adults. And this is really that pubertal versus prepubertal concept. So for prepubertal patients, pediatric patients, oftentimes if abuse has not occurred within the last 24 to 72 hours, we will not collect DNA forensic evidence because most often that DNA is on the external portion of the body. And our data shows that we don't find it after 72 hours, with the exception of at the scene. So on things like towels or clothing that are at the area or location where this has happened, or in a garbage can, for instance. There has to be a clear history of sexual assault, contact, so trauma, ejaculation, kissing, any type of oral sex. There might be genital or anal trauma present, and we will do an abbreviated forensic evidence kit or rape kit based on that disclosure. In adolescents or pubertal patients and adults, we will collect evidence from 120 hours from the time of the assault. So if the assault happened at 3 p.m. today, you could go out 5 days or 120 hours from this moment in time. And again, we take that history of a clear history of sexual assault, contact, so trauma, ejaculation, kissing, oral sex, and you're really thinking about body fluid contact, so you know where to swab and what to swab. And then part of your exam is really making sure to look for any genital, oral, or anal trauma that might be present. And then Afnan, did you want to talk about the risk assessment?
Yes. So the slides emphasize the critical process of risk assessment in reported cases of child sexual abuse. And at this stage, our goal is to gather all relevant information. We can do that through observation. For instance, we can go for home visits, trying to find out if there is something suspicious, any signs that could give us clues. We need to look for reports, interviews, forensic investigation, agencies' records, for instance, as stated before, the medical record and other records. And then after collecting all the data, we analyze it carefully to determine both the level and the type of the risk, and I might say also the severity of the risk to the child. We focus on facts, not assumptions, and this is so important to emphasize. This means that what we observed or what is documented or what is reported. And key activities includes observing, investigating, assessing the potential for future harm. We can use guiding questions like, what exactly happened? Who was involved? Is the child currently in danger? And what is the likelihood of future abuse or future harm? And the outcomes of this process should be clear, should provide us with a professional picture of the situation, one that supports a well-informed decision on the next steps, whether that is an immediate protection response, reporting, or support within the family or the community. And the clock figure that we added here, the clock graphic, is a reminder that time matters. Delays can leave the child exposed to ongoing risk, so timely and thorough assessment is essential. Dennis, do you want to add to that?
No, that's great. I appreciate that. Thank you.
Thank you.
So we had a few summary and key takeaways to think about rather than a checklist to think about. We think it's really important to have a coordinated response, thinking about local resources, victim advocates, how law enforcement, child welfare, and medical personnel might interface together and interact together. We also want to consider developing protocols to help identify and respond to victims, and there's clearly more research needed in these areas, but utilizing tools to help with this is very important so that we have a systematic approach and do it the same way for each person, understanding that there will be nuances and differences in each person's history. And talking about body and emotional safety with your clients and your patients. Ideally, we can try to be non-judgmental, trauma-enforced, evidence-based in our healthcare, as well as care outside of a medical setting. And that includes recognizing our own personal biases that we all have and how that impacts the care that we give. And then really importantly is thinking about self-care, because we cannot continue to come and do our work if we're not also taking care of ourselves. And the stories that we hear, the histories that we hear, the families and children that we interact with have traumatic events that happen, and that trauma will overlie to us as clinicians and professionals working within this field. And so really being cognizant of how you take care of yourself, and learning this early in a career so that you can develop a long career is important. So we, again, are showing our guiding questions that we will discuss in more detail in our breakout sessions. We appreciate everyone's time and look forward to questions.
Thank you to Afnan and Denise. Just a reminder, they will be available after breakouts for an open Q&A session. I know there's a lot of thought-provoking information that was shared, and we're anxious to allow you an opportunity to really ask those questions and, figure out how this information can help you in your work, in your regions, and to build better support systems for kids. Now we're going to go to small group breakouts, and I just want to explain a little bit about the breakout rooms. Each breakout room will be facilitated by a member of the HUDDLE Curriculum Steering Committee. And today we have the luxury of having multiple members of the committee with us, so you may have one or two people in your room, which is just such great opportunity to connect with these experts who develop the curriculum for these last 5 weeks. When we start the breakout rooms, you're going to receive a prompt to join. We're just asking that everyone hits that button, excuse me, and joins a room. In the breakout rooms, you're going to have the ability to turn on your microphones and your cameras to participate. Obviously, the cameras are optional, but it's going to be a small, intimate environment, and we'd really like to see you and hear from you and, allow you to share your situations in a much more intimate room to do that. The first 3 minutes of the breakout, we're going to be taking a brief poll. So that will be conducted by our Haruv support team. It is a 4-question poll and very short 1-2 word answers. We're not going to share the results of that poll in the breakout room. So you'll take the poll and then we'll share those when we return to the main area. So it would be an accumulation of all 4 breakout rooms answers. And then we'll allow Afnan and Denise to comment, as well as the rest of our facilities, on those answers in that poll. After the poll's done, we really hope that you'll take time to introduce yourself. Your session facilitators should guide this for you, but we really want to know, where you're from, your discipline, why you joined us today, and your region. So please make sure that we take an opportunity to do that before hitting the 4 guiding questions that'll be on your screen in the breakout rooms. And then the breakout rooms are not recorded. So just so you know, the main session is because it lives in our knowledge hub. So everyone has access to this information post today's session, but the breakout rooms are not. So you have the ability to speak openly and candidly and honestly and ask your questions. After 40 minutes, you'll be automatically returned to this main session and we'll do the open Q&A. So I'd like to now open the rooms and hit your buttons to join.
I didn't get a button.
Hello, everyone, and welcome back. I think all our rooms have returned. And at this point, I'd like to encourage all of our panelists to leave their mics and cameras on. Lil's going to share the feedback from the word cloud to the Mentimeter poll, and then we'd like to just have a great open discussion. If any questions came out of the breakout rooms that you would like to use this opportunity to type in Q&A, that would be great as well. I know some broader concepts were discussed. I do want to let everyone know that our panelists today really represent multiple disciplines. We have judicial, we have legal, we have medical, we have social work. So it's a great mix of expertise as we slide into Q&A. So Lil, if you want to put up your slides for Mentimeter results, that would be great. And Denise and Afnan, if you would like to comment on the results and see if you had any surprises or if there's information here you would like to kind of use to make additional points.
Actually, I like the thing that there is no dominant response here and about the diversity of the responses. Maybe we could talk about some of these points, but if I want to talk about the age appropriate or the age developmental practices that could be used in the assessment process and ensure that our intervention is trauma-informed and context-sensitive, I would think one of the examples that came to my mind is the forensic investigations. And I'm not a forensic investigator by myself, but as a child protection social worker, I received many forensic investigations, and I have, may I say, an understanding how it's looked like. And for instance, at the beginning of the interviewer explained the rule in a way that the child can understand it. I mean, in very simple words. The interviewer say, my name is, for instance, Fnan. My job is to talk with children about things that may have happened to them. And then he makes sure that the child understands that they are there to listen and to help them whatever they are going through. And I also remember that the part that they explain about the camera. Why is there a camera in this room, which might be terrifying experience for children. So they explain that the camera is being used during the interview, and they might also say, as you see, I have a camera here. The camera will record our conversation so that I can remember everything you tell. And sometimes I forgot something. I mean, I forgot things. So the camera helped me to listen to you without needing to write everything down. So I think this is the first thing that came to my mind about making our practices age appropriate and support choice, support voice, and also give a sense of control to the children.
Denise, anything you want to add?
No, this is a really nice summary of the information that was presented.
Do you see anything that might be potentially missing from this list of a reason why a child would be referred?
I said in our small group, I realized that I am a medical professional and I am in the business of doing exams, but I actually really think that all children, all adolescents should be offered an evaluation. Whether or not they have that assessment is, again, giving them bodily autonomy in some sense and having family discussion around that. But allowing them the opportunity, I think, is very important to have an assessment, which can be very therapeutic in terms of understanding what their body looks like and any worries that they have about their body, where they might not have an opportunity to ask those questions or get that reassurance in a different setting.
If I can interrupt, that actually came up a lot in our breakout room, where even if there weren't symptoms of physical trauma, the opportunity to be able to talk to a medical professional. And Antonia was great. She was able to talk about what that looks like. And just telling a kid, hey, your body's okay. No one can tell by looking at you that abuse happened. Again, regardless of what kind of abuse actually took place. That was something that we discussed at length in our breakout room.
Thank you, Sarah. I would like to add 2 points about that. The first thing is that the medical exam is not just about collecting evidence, as Dennis also told us previously. And sometimes it's about giving the child peace of mind. And I also shared that in the breakout room, that many children don't know what's going on, what happened to their body, is there anything that happened wrong? I mean, and I also say that we as adults, when we have a medical check, we are afraid, don't know what to expect or what is happening inside us. And I think that's going to be, it could be a stressful experience for children to go through the medical exam. So the sensitivity and to be aware of how this might impact the child and how we can address their concerns is very important. And another example that came to my mind that I want to emphasize here is that the legal evidence could be used in a very bad way. And I can tell you briefly that I had a case of a sexual abuse from the brother against his sister. And what happened is that in my country, to approach medical examination, you could have the consent of the parents, or otherwise, if you don't have the consent for the parents, you should have a decision from the court. And in this case, the parents gave consent. They consented on having the medical examination for their daughter, but we found out later that they wanted to have an evidence that nothing happened and to blame her with that. And I mean, sometimes we should think about how any practice that we can make could be interpreted or framed or used for other, may say, interest. So this is very difficult, one of the most difficult cases that I'm involved in, but actually this should also be acknowledged and also addressed.
I think that's so important. We didn't talk about this in our group, but the cultural context is vital. There are still misconceptions in certain places that the medical clinician can look at the body and tell exactly what happened, or that certain types of abuse equal injury all the time. And so I think that's such an important piece to point out. And then there's also the other cultural aspect about what it means to have injury to your body and how that may stigmatize an individual who's experienced sexual abuse. And so even for children who have an injury, they know they have an injury once they've healed. I often reassure them and tell them that, again, no one is going to be able to look at their body and know that I'm sort of specially trained in this area, that their body is healing, and that is not going to be obvious to people that perhaps they have relationships with later in their life.
Denise, that came up a little bit in regards to the forensic interview. I think it was 120 hours is for an adult and the 24 to 72 hour ideal forensic time period. But what about past injury? I think, Antonia, you were just hitting on that. Like what can be trained to look for past injury, or what needs to be trained to look for past injury? And
yeah, I mean, it can be very, very difficult. So your genital tissue is going to be mucosal tissue, which heals quite rapidly and often with either non-specific or difficult findings to make a determination of yes, abuse occurred or no, abuse didn't occur. There are some exceptions where there's been significant injury, but even still in kids that we've seen over time to watch injury heal, If you only saw the last point in time, which might be weeks to months after an assault occurred, you might not be able to tell that that injury was ever there. And that's part of the challenge in terms of the medical evaluation, identifying with specificity that there was a prior injury. And we also always peer review every single case that we see, especially if we have a concern. So I have the value of in my office, I can walk 2 doors down and I see Antonia, or I can go upstairs and Kathy is there so that we can all have discussion and consensus amongst expertise, which is really hard to do in some areas in locations because there's just not that resourcing available. But I would caution that I think the physical exam in a non-acute setting is much more to reassure people about their bodies and much less to say that there was specifically an injury which is diagnostic of abuse.
Thank you. Lil, do you want to move on to the next? This one speaks to multidisciplinary collaboration, which again is the whole focus of the huddle. So I'm curious, the comments of all of our panelists in regards to, how do we support this? How do we make this happen? Adnan, do you want to start? I know you spoke very eloquently about the need for this.
Yes, this is, one of the most important aspects of good assessment. I'm just wondering the communication here. I think it's in good aspects. In good meaning, in a positive meaning, may say. So, what I can say that if we don't have, if you don't communicate with professionals from the other sectors, if you don't have collaboration, or may say, collaboration fails when people assume someone else is taking care of the child. This is a big problem. And trust between professionals about shared responsibility and a system, or may I say systems, that doesn't let the children fall through the cracks, which is very important because if you don't have a good communication or collaboration or clear rules, as we see here in this figure, children are gonna fall through the cracks. So I've been seeing cases where poor collaboration led to harmful delays and children paid the price, may I say. So yes, it is a shared mission and we should acknowledge that. And we should all the time think that what are the ethical principles that lead our practices and our communications, which is super important. One of the things that was said in the breakout room that I was engaged in, is that there are hierarchies, and we know that some professionals have more authorities than other. And one of the most important thing that was said there is that we should hold with empathic, may I say, empathy and respect, mutual respect, because this is super important. And I can tell you, if we don't have all of these beautiful elements that we see in front of us, there's going to be a gap, because even though that I have many authorities and can access any record I want, I can tell you that we could find gap between what was reported via phone calls and what we received on papers. So we should work a lot to build a trust and a good coordination and collaboration between professionals.
The one thing that you talked about, Denise, was duplicative questions and, re-traumatizing children, in the process of engaging other disciplines. And I don't know if, you would like to speak to that, how you avoid those duplicative questions, or again, to any of our panelists as well. I know many of you work in multidisciplinary teams.
Yeah, it's one of the reasons that when I start an evaluation, I try to figure out what has happened before coming to me. So am I the first person interacting because you came to an emergency department and I'm seeing you medically? Or has this already been reported to either child welfare or law enforcement? and what's happened through the course of their investigation to get you to my ambulatory or outpatient clinic. And it's sort of a different pathway depending on which place I'm at. So if I'm in the emergency department and the first person interacting with a child and a family, I ask only the questions I need to know to understand how to best do their medical evaluation and what concerns that child has about their body today, so that I can address those issues. In my outpatient clinic, I might actually already have the information from the forensic interviewer from law enforcement or a social worker who's talked to the child or family. And then I will say, I've heard about some things that have happened to you. What would you like to tell me today? And I would like to do a medical checkup so that we can talk about any worries you have about your body today. And then we come to some sort of shared decision making around what that might look like. But it really, this is where having an algorithm becomes really hard, because I don't know in my setting where in the line of things that need to happen I might be seeing this patient and evaluating them medically. I don't know, Jane, if that answers the question.
No, it definitely does. And I think, you just hit what we're seeing in the slides, the level of communication, the level of documentation, the clear roles of, who handles what part of the assessment, I think really speaks to that going smoothly in the process you outlined.
If I could jump in, June,
Oh,
just to
absolutely.
comment on this slide in particular. So in our session, Maria from Romania made a very interesting comment, because she said, of course, there is always the ideal of having a Barnhouse or a bona fide model, but in an environment that is not as well resourced, where you can't have that, and persons are working from their different departments or offices separately, it would be very important to have, and I see it here, protocols, but something that's not here that you mentioned was to perhaps have a very vibrant and shared database, so that each person in the sector who is working from a different location can feed in what they did and the outcomes of their intervention, so that the other partners who are in other buildings and ministries and departments and agencies can actually see what was going on. So there's a continuum of care, which really puts the child at the forefront of the intervention. So I think that shared database is a good one.
A great point, Diane. Lil, do you want to move to the next slide? Well, Afnan, and Denise, I hope you're happy with these answers. I think people grasp, how to have a child-centered assessment process. I think it's difficult where maybe some disciplines are missing in remote areas where people are filling in, whether it be for mental health or for, other areas that they might not have access readily available as part of the initial process. But again, I think this is the gold standard. The goal is to have all these things in place.
Yeah, and I think just talking to kids in a child-friendly way can be really child-centered, and remembering that using language that they're going to understand, not talking in a lot of jargon, which is relevant to your expertise, whatever that might be, but sometimes just sitting down and talking to kids and building some rapport and trust can really be helpful in terms of being focused on the child and where they are in this process. And frankly, like, we allow them to play with the medical tools that we use to do our exam and our evaluations. And if they want to listen to their heart during their evaluation, I take off my stethoscope and I clean it and give it to them. And then they get to listen to hearts and lungs and do these pieces that you would do in a general pediatric assessment as well. So really just going back to being a generalist sometimes is really important. And then coming back to the expertise of thinking about child abuse or child-centered child maltreatment evaluations is really important as well.
Jane, could I just ask one kind of elephant in the room question about when the parent, sorry, I have things that are like burning in my brain sometimes about when the parent is the perpetrator and they are in the room. How do you deal with this? Especially like in the case of Sasha, you know, or there is one of the parents may not want him to disclose or is afraid of what is going to happen to the family. How do we deal with this and also make sure that we're, of course, always protecting the child first, but not making that child also more disturbed or scared?
So
Don't
it's,
typically allow the perpetrator in our clinic if we know that person is there.
Well, if they're the
I-
mother or the father and you don't know that yet.
Yeah, my sense is it's relatively uncommon, although I absolutely acknowledge that may be a possibility. I think that that's where you have to depend on your local laws. So, you know, if we had a parent who we felt like was potentially the perpetrator and impeding care, that's a place where I would reach out to either social services or the police. And so within our location, we have laws around that and other options for support. But I think it really is dependent upon your local setting. And that's where it's important to know those laws and have those resources.
yeah. And Tony, I might also add, this is where we sometimes will say, I'd like to talk to your parents before talking to you. And so we'll have a child life specialist or other professional with the child in a separate space. And if in that portion of talking to a family member, I get the sense that they're not supportive or that they might be the offender, I might take a pause to care for a minute and say, like, let's talk about what I'm hearing and what that means in the context of what your child has said and why you're in my clinic, knowing that I work in a child abuse clinic. And or if I'm worried that the parent is the offender, I might take a pause and say, I just need to check on a few things and then go back to my workspace and say, I need to really talk to law enforcement or child welfare to help me understand what I can do in this context of this evaluation. And today might not be the day, if it's non-acute, to do that medical evaluation, because I don't want to do it in a way that's going to be unsupporting to that child. But you'll have to know your local resources and laws, and it can be really challenging.
I think it's more of a question. I think we're so far ahead upstream in the path of the crisis that most often we're seeing kids who are coming with a non-offending parent. I think it's a really great question for those maybe downstream general, you know, practitioners who might be seeing kids before a disclosure, like we saw in Sasha's case and how that was handled. So really important question, but I feel like for us who are kind of doing this work a little bit later down the road, it's less common. Not to say that we don't always have supportive parents. They may be non-offending parents, but oftentimes there is a dynamic where they're not necessarily supportive of the child, and that's also a complication that we have to deal with.
Absolutely. So I want to acknowledge that we are at time, but we do have questions coming in. So I would like to obviously offer the option to anyone who needs to go. I know everyone has dedicated their time, both the attendees and our panelists, but I'm also happy to keep the recording going a few minutes if you want to take additional questions, but I just wanted to acknowledge that we are in fact at time for the session. So, you know, Denise, Afnan, if you need to go, let us know if any of our panelists do, but if you want to take a few questions from the audience, Lil, I'll have you stop sharing and we'll just go through what's in the Q&A if you're able. And Afnan, I think you answered this Q&A question about parents who withhold consent unreasonably. And again, sometimes kind of waving in Pregnancy's point, sometimes the people who would offer consent are the people who may in fact either be the abuser or know within the family they're protecting someone who could be the abuser. But I don't know if you want to speak to that again briefly about how do you handle the lack of consent?
All right, again, just add to what I said before is that in many cases where we know that the caregivers or the parents are not the perpetrators, and for instance, we have other family member which is the perpetrator. For instance, in the case that I told about before at the beginning, it was the brother. and the brother was arrested immediately after the forensic interview, because we have already evidence that sexual abuse was happening there. What I can say is that we knew about the parents' responses to the disclosure, and they were blaming the girl, and we knew that this girl shouldn't stay with these caregivers because otherwise it's going to be a very devastating experience for her. And our response was to immediately take her to emergency center and to begin a long process of intervention. Because I can say, and one of the points that is raised by survivors, child sexual abuse survivors in our research, is that the response, the initial response, even though it's not, I'm not talking about the perpetrator, from the family members, from the professionals, if it was negative, stay with them all over their life. I mean, all the time, one of the things, the first thing that they share when we ask them to share their story, to understand what happened there, or to understand based on their expertise and experience, what they want to share us is the initial response, how other people, not the perpetrator, again, not the perpetrator, because they know that how the perpetrator might respond to that disclosure, but how other family members and how other professionals reacted once I disclosed the sexual abuse. And I can't say in words how much huge and tremendous impact this response have on the lives of survivors.
Amazing, thank you. I think what both of you did so well is to really put the child first, you know, and Denise, you really hit that home in the medical assessment. Afnan, you definitely did that in the whole ecological approach and holistic approach to the child. So that message came through loud and clear today. So I hope you feel really good about that. I want to offer it now if there's Pragati, Diane, Sarah, any last questions or comments or from any of our panelists? And if not, Denise and Afnan, you know, any last minute things that you'd like to share?
Right,
Wait,
so
I
I
have-
do have, okay, sorry, go ahead, Pragati, I'll go
No,
after
you
you.
go, Diane. No, go.
Okay, all right. So I just wanted to chime in on the question you asked, Jane, about where the parent is withholding consent to the medical examination or just doesn't want to cooperate. So Jamaica has a very interesting model because we can, through the Children's Advocate, which ironically happens to be me, dispense with parental responsibility and the right to be giving any kind of approval for that particular instance, if we can establish that we're asking to dispense with that parental right for the purposes of advancing the child's best interest. So usually when making the decision, it includes my legal assessment and also very active consultation with the medical practitioner who's managing the situation as to what is medically your opinion, that we should be doing in this case. And of course, very importantly, consulting with the child to hear what the child actually wants. And if those three things line up, then we move ahead with dispensing with the authority of the parent, and the Children's Advocate then steps into the shoes of the parent for the purpose of giving the medical team the consent that it needs to proceed. So just wanted to add that as well as a way to approach parents who may be offending and may not be willing to consent, or who may be non-offending, but because they are a little bit apprehensive about, the what ifs and they want to protect the perpetrator, etc. That's how we tend to deal with those difficult situations. So just wanted to put that on the table. Thank you.
Oh, it's very interesting, Diane. And Denise, we don't have anything like that in the States that I'm aware of, correct? To bypass parental consent, like an advocate of some sort.
You do. You should know in the United States, know the local laws, but like for instance, in Children's Code allows us to, did I lose you all again? No?
No, I can hear you.
Maybe.
We can hear you.
We can hear you, Denise.
I don't know if you
Denise, maybe turn off your camera. It might help your bandwidth.
I can pop in. In Colorado, we have a state statute that allows us to do exams and tests and stuff like that in the situation of child abuse and neglect outside of the consent from the parent. Our sex assault reporting laws require that we make best effort to inform a parent about a sexual assault unless that person is the perpetrator, it puts the child at risk. So there are often, I think, carve-outs in the law for these settings situations.
Does anyone else have any other questions? I just have, these are so interesting for me and to understand even the process, but I want to allow our attendees, does anyone else want to ask a question? Okay, because of course I have like 3. Okay, so I'll start with mine. So what if the child doesn't want to name their perpetrator? Is there any legal requirement that they have to do that for you to move forward with the investigation? No.
No.
Okay.
No,
that's good.
we would still, by mandatory reporting laws in the United States, have to make a report, but that piece is outside of our medical sort of sphere that we work in, and the investigators would have to interface with that piece of it.
Very common,
so if they don't want to bring the case.
Yeah.
What, Antonia?
I was to say that the process of disclosure and hesitancy to disclose is super common, again, like we saw with Sasha. So yes, of course, you can't have a legal case without a perpetrator and someone who has been identified as committing the crime, but we can do things to help kids when we're worried about abuse before they've made a disclosure.
To still heal, yeah. So I guess I'm a little curious too, why, knowing that this would be useful for pediatric exams and we have well checks and regular things, why is this not part of a pediatric well check? And is this something that maybe we need to work on advocating for with the AMA? Is this something, why does this not happen as a routine check if it would be useful in the well check to ask a child? You had mentioned before that, we could sometimes do this assessment of children on a more regular basis, or even
so Pragati, if I'm understanding, like part of a general well child evaluation should be including looking at kids' genitals to make sure you're not missing something medically as well, right? So kids can have precocious puberty or other issues related to genitals that are not related to sexual abuse, that their general healthcare professional should be looking at during a true well annual exam that are happening. And I think there are lots of places now that are doing much more detailed screening around behavioral health development. And as part of that screening, some people are asking about things like social determinants of health and child maltreatment. But it depends on where you are and what that looks like in your clinical setting. Oftentimes, general healthcare clinicians are just not comfortable with what they're looking at when they're doing the medical evaluation. And so sometimes we'll want to refer to a specialist if they see anything that looks just a little bit different or unusual to them, which I also think is very reasonable.
Okay. And then I guess my last question is, if you have some suspicion of abuse or neglect, is there ever a circumstance where you would advise kids to record or gather evidence on their own if it was possible for them, or if something happened that they weren't sure about, and do you ever go down that path with assessments or evaluations to, I don't know, try to help the case or help them figure out? No, you don't even suggest this with.
I have not, that has not been part of my practice. I also think it's really important for us to remember that we have multiple lanes who are doing these evaluations when we're thinking about child maltreatment, child sexual abuse. And for me to be a credible witness when I have to testify in court, I want to make sure that I am staying in my lane of I perform medical evaluations and I am not an investigator. And so I don't want to be placed in a scenario where I can't actually put medical hearsay into testimony or talk about my evaluation because I've moved into the role of investigator by saying certain things like perhaps you should do this or that in terms of trying to figure out who might have done whatever to whatever child. And so I tend to be very clear that this is my role and I don't have space in these other places. I clearly interact with law enforcement and child welfare because I have to share information about what I am finding, but this is my expertise and that's where I lean in. So I have not done that in the past.
Would you say the same, Afnan? You stay in your
I,
lane?
yes, I mean, this might transfer. I mean, even if we didn't have any intentions for that, this might be interpreted by the child that it is his responsibility or her responsibility to have an evidence for the abuse. And I think that it's our responsibilities and as adults to help them and not to add any burden or their like small shoulders. Because yes, I wouldn't think about that, but what I would think that if I want to take your idea is to be innovative. I mean, to be innovative as much as we can, and to do anything that we can help the child to disclose or share with us. And I think, and briefly, I'm gonna talk about the child's sense of control in situations where it is relevant, it is important. I think that they already underwent sexual abuse. They feel that they lost the control on their bodies and on their lives. And what I think is that we should be innovative, for instance, when they are investigated, to ask them if it is okay to continue. How are you feeling currently? I mean, now. And we can also think about using traffic light card system with like young children who could hold up a green card to continue, a yellow card to pause, and a red card to stop. I mean, we should think all the time how we can give them a sense of control among all the things that are happening, because if we don't, they will feel more and more losing control in their lives. So I think it is our responsibility to be to embed practices that ensure the child's voice, sense of control, and dignity in all the things that we are doing.
Very beautifully said. One question did come through Q&A about Stockholm Syndrome, about children who have trauma bonded with their perpetrators, who may not recognize the acts as wrong because they've been told differently. Like how does that affect, the examination, the assessment, like how?
I could say that the identification with the perpetrator is one of the most challenge that we handle and address. I mean, during the assessment and during the intervention. And if I want to reflect on all the cases that I was involved as a child protection social worker, I don't remember any child that was happy with the decision to take them out of home place or to take them to emergency center. I do remember children yelling at me, crying, wanting to go back to their homes and perpetrators because they have like this complicated experience that they do love them, because the perpetrator do not groom the children by only doing in negative experiences. They also provide them with some sort of positive experiences, which make the child to be confused of who is I'm dealing with. I mean, this father sets me with other things, bring me gifts. So how can I hate this father who is at the same time abusing me? So I can say that it is a challenging thing. And what I think that we should consider is that during the immediate response, when we take children out of home place, for instance, to shelters or emergency centers, we should hold on a little bit and talk to the child, because me and Dennis, we talked about that previously, that we feel more comfortable to talk with adults than children. And we should talk to the child, telling him, I know it is difficult for you. It is hard to be far away from your home, family, friends, siblings, but I do care about you. And we see that, I mean, for the long term, we see that children are very creative and very clever creatures that do understand when we take care about them, even though that they don't like our decisions or our decisions don't align with their desires.
I thought that dynamic was so compellingly portrayed in the documentary by Sasha's father, who said sometimes the abuse felt good. Remember that? He used those words. And he talked about one brother being more loving and supportive and protective, and the other being more aggressive and manipulative. And I think he was conflicted, right? And I think it played a role probably in how he viewed the likelihood that those brothers might perpetrate on his own son. So I thought, wow, how powerful for this man to be able to say that in such a public forum. It's so stigmatizing to say abuse could have felt physically good to me. I just found that so powerful and just transformative for someone who might have experienced that same thing to have that level of validation, because it is so common in these situations. So common. And that's why we always talk about, if you've experienced this, especially the level of familial incest, like we saw in the documentary, you have to have treatment by someone who's really experienced in this area, who knows what the evidence-based treatments are and have an understanding of them.
That's excellent. Excellent point. All right. So I feel like, in respect to all of your time, it's 30 minutes past. You've been so gracious to stay on with us. For our audience, again, many of you stayed on as well. Just a reminder that session 4 next week will deal with collaborative response, things we touched on today, but they'll go really in depth in this area. And then session 5, the last one, will actually have Sasha back to really tell his story and, and beyond the film, what life looked like then and now for him as he shares his message. So again, thank you to everyone. Again, Denise Afnan, you were amazing. Your presentations are amazing. Your expertise is so valuable. And to the entire team at Children's, thank you for joining us. To the Haruv team, to our facilitators, again, just many thanks. And we hope we see all of you next week for session 4. Thank you, everyone.